Acquired hemophilia, practice essentials. Acquired hemophilia is a rare but potentially life-threatening bleeding disorder caused by the development of autoantibodies, inhibitors, directed against plasma coagulation factors, most frequently factor VIII, VIII. Acquired hemophilia can occur in the context of a variety of disorders, including autoimmune diseases and malignancies, or as a drug reaction, but approximately half of cases are idiopathic. Signs and symptoms: patients with acquired hemophilia may have no bleeding, mild bleeds, or life-threatening bleeds. Most patients present with hemorrhages into the skin, muscles, or soft tissues and mucous membranes. Intra-articular bleeding episodes are uncommon. Diagnosis: laboratory study results in acquired hemophilia are as follows: the activated partial thromboplastin time, APTT, typically shows a prolongation that is not reversed on a correction study. The bleeding time, prothrombin time, PT, and platelet count are normal. Reduced VIII levels and evidence of an VIII inhibitor are critical to the diagnosis of acquired hemophilia A. Other factor levels should be determined to establish inhibitor specificity. Once the acquired inhibitor is detected, quantification of the level may be useful in selecting hemostatic therapy in patients who require it. Testing to exclude lupus anticoagulant, e.g., dilute Russell Viper venom time and the kaolin clotting time, is indicated if APTT values during the mixing study are similar at time 0 and after incubation at 37 degrees Celsius. Screening for heparin is also necessary. Management. Therapeutic options in acquired hemophilia include the following: treatment of the underlying disorder or discontinuation of an offending drug may eliminate or assist in the eradication of the inhibitor. Clinically relevant bleeding can be treated with recombinant VIII porcine sequence, RPFVIII, if the baseline anti-porcine VIII inhibitor titer is less than or equal to 20 bulletin, recombinant activated factor VII, RFVIIA, or activated prothrombin complex concentrate, APCC. The choice is determined by the agent's availability and cost, and for RPFVIII baseline anti-porcine VIII inhibitor titer and ability to monitor RPFVIII. If the patient has a low VIII inhibitor level, 5 bulletin, and other options are not available, human VIII concentrates may be used to control bleeding. However, no dosing guides are available and massive doses may be required. Hemostatic prophylaxis is indicated for patients at high risk of bleeding and for invasive procedures, both minor and major. If possible, invasive procedures should be delayed until the inhibitor has been eradicated. Prophylaxis can be with RPFVIII, RFVIIA, APCC, or emicizumab, off-label. Eradication of the inhibitor with immunosuppression should be initiated as soon as the diagnosis of acquired hemophilia is established. First-line therapy for inhibitor eradication is with corticosteroids alone or combined with rituximab or cyclophosphamide. Salvage therapy with cyclosporin is particularly effective in patients with underlying systemic lupus erythematosus. Background: acquired hemophilia is a rare but potentially life-threatening bleeding disorder caused by the development of autoantibodies directed against plasma coagulation factors, most frequently factor VIII, VIII. Autoantibodies against other factor proteins have also been reported. Because inhibitors to VIII are the most frequently observed in clinical practice, this article focuses on the etiology and management of VIII autoantibody inhibitors, or acquired hemophilia. A diagnosis of acquired hemophilia can be difficult, both because the condition is rare and because the patient does not have the usual personal or family history of bleeding episodes, such as is seen in congenital hemophilia. Moreover, the clinical signs and symptoms of acquired hemophilia differ from those of hereditary hemophilia. The severity of acquired hemophilia at clinical presentation can also make its management challenging. Treatment strategies for acquired hemophilia have two major objectives. During acute bleeding episodes, effective control of bleeding manifestations is the primary objective. However, the ultimate therapeutic goal is to eliminate the inhibitor and cure the disease. Please see the following for more information: Hemophilia A. Hemophilia B. Hemophilia C. Pathophysiology. Acquired hemophilia is a spontaneous autoimmune disorder in which patients with previously normal hemostasis develop autoantibodies against clotting factors, most frequently Viine. The development of autoantibodies against Viine leads to Viine deficiency, which results in insufficient generation of thrombin by factor IXA and the factor VIIIA complex through the intrinsic pathway of the coagulation cascade. The development of factor IX, FIX, autoantibodies is less common, and the presence of autoantibodies against other clotting factors II, FII, V, FV, 7, FVII, X, FX, 11, FXI, and 13, FCA, as well as von Willebrand factor, VWF, is extremely rare. The most common epitopes for autoantibody binding to Viine appear to occur between amino acids 454 to 509 and 593 in the A2 domain on the heavy chain of Viine, between 1804 and 1819 in the A3 domain on the heavy chain, and between 2181 and 2243 in the C2 domain on the light chain. Anti-C2 antibodies inhibit the binding of Viine to phospholipids and may also interfere with the binding of Viine to VWF protein, whereas anti-A2 and anti-A3 antibodies impede the binding of Viine to activated FX and FIX of the intrinsic pathway FX activation complex. Although both alloantibody inhibitors in patients with hereditary hemophilia and autoantibodies in patients with acquired hemophilia appear to recognize the same epitopes on each domain, the inactivation of Viine resulting from these interactions differs. For example, alloantibodies totally inactivate Viine activity according to type 1 kinetics, and this total inactivation is not dependent on the titer/concentration of circulating antibody. In contrast, autoantibodies typically exhibit more complex type 2 kinetics, undergoing an initial rapid inactivation followed by a slower inactivation curve and resulting in some level of residual Viine, which can be detected in the laboratory but does not seem to convey useful clinical efficacy. Etiology: acquired hemophilia results from the development of autoantibodies, mostly of immunoglobulin G IgG subclasses 1 and 4, directed against clotting factors. Numerous conditions have been associated with acquired inhibitors to Viine. Rarely, Viine autoantibodies arise as idiosyncratic reactions to medications. However, approximately 50% of cases are idiopathic, arising in the absence of relevant concomitant diseases or medication use. The following conditions may be associated with acquired hemophilia: A. Pregnancy. Autoimmune disorders. Inflammatory bowel disease, ulcerative colitis. Dermatologic disorders, e.g., psoriasis, pemphigus. Respiratory diseases, e.g., asthma, chronic obstructive pulmonary disease. Allergic drug reactions. Diabetes. Acute hepatitis B infection. Acute hepatitis C infection. Malignancies: solid tumors, prostate, lung, colon, pancreas, stomach, bile duct, head and neck, cervix, breast, melanoma, kidney. Hematologic malignancies. Autoimmune disorders may include the following: rheumatoid arthritis, systemic lupus erythematosus, multiple sclerosis, temporal arteritis, Sjogren's syndrome, autoimmune hemolytic anemia, Goodpasture syndrome, myasthenia gravis, Graves' disease, autoimmune hypothyroidism. Allergic drug reactions may occur from the following: penicillin and its derivatives, sulfamides, phenytoin, chloramphenicol, methyldopa, dipothiaxanthine, interferon alpha, fludarabine, bacillcalmette-guerin, BCG, vaccination, disvenlafaxine. Hematologic malignancies may include the following: chronic lymphocytic leukemia, non-Hodgkin lymphoma, multiple myeloma, Waldenstrom macroglobulemia, myelodysplastic syndrome, myelofibrosis, erythroleukemia. Underlying diagnoses in 3 cohort studies of acquired hemophilia A are listed in Table 1, below. Table 1. Underlying diagnoses in patients with acquired hemophilia A. Disease association. Green 1981, N equals 215%. Morrison 1993, N equals 65%. Collins 2007, N equals 172%. Idiopathic. 46.155.0. 63.3 collagen, vascular, and other autoimmune diseases. 18.0 17.0. 16.7 malignancy. 6.7 12.0. 14.7 skin diseases. 4.5 2.0. 3.3 possible drug reaction. 5.6 3.0. NR pregnancy. 7.3 11.0. 2.0 other. 11.8 NR disorders believed to be associated with inhibitors to coagulation factors other than VIEN are shown in Table 2, below. Table 2. Acquired bleeding disorders associated with inhibitors of factors other than VIEN. Coagulation factor inhibited. Most commonly associated disorders. Treatment. V. Lymphoproliferative disorders, adenocarcinoma, tuberculosis, aminoglycosides, topical thrombin. FFP, RFVIIA. 9. Systemic lupus erythematosus, acute rheumatic fever, hepatitis, collagen vascular diseases, multiple sclerosis, post-prostatectomy, and postpartum. Fixed concentrates, APCCs, RFVIIA, corticosteroids. 11. Autoimmune diseases, prostate carcinoma, chronic lymphocytic leukemia, chlorpromazine. FFP, FXI concentrates, RFVIIA, tranexamic acid, fibrin glue. 13. Idiopathic, isoniazid, penicillin. C8 concentrate, FFP, stored plasma, cryoprecipitate. VWF. Autoimmune disorders, monoclonal gammopathies, lymphoproliferative diseases, epidermoid malignancies, hypothyroidism, myeloproliferative disorders, and certain medications. Desmopressin, infusion of VIEN that contains VWF, IVIG, plasma exchange. 2. Topical thrombin, idiopathic, autoimmune diseases, procainamide. APCC, FFP. 7. Bronchogenic carcinoma, idiopathic. Fixed concentrates, APCC, VIEN concentrates, RFVIIA, fibrin glue, tranexamic acid. X. Amyloidosis, carcinoma, acute non-lymphocytic leukemia, acute respiratory infections, fungicide exposure, idiopathic. APCC, tranexamic acid, fibrin glue, FFP. APCC activated prothrombin complex concentrate, FFP fresh frozen plasma, IVIG intravenous immunoglobulin, VWF von Willebrand factor. Prognosis, because it is frequently confused with other life-threatening conditions, e.g., disseminated intravascular coagulation, and typically occurs in an elderly population, acquired hemophilia can lead to severe morbidity and even mortality before it is correctly diagnosed. Estimates of the mortality associated with acquired hemophilia range from 7.9% to 22%, with most hemorrhagic deaths occurring within a few weeks of presentation. More than 80% of patients with VIEN autoantibodies hemorrhage into the skin, muscles, or soft tissues and mucous membranes. Muscle bleeding episodes can be severe and can lead to compartment syndrome and tissue death. Other manifestations include prolonged postpartum bleeding, excessive bleeding following surgery or trauma, and, occasionally, cerebral hemorrhage. In general, the prognosis of patients with acquired hemophilia depends on the patient's response to immunosuppression. A meta-analysis of 249 patients with acquired hemophilia found that 3 factors had an independent impact on overall survival and disease-free survival: Related conditions, malignancy vs postpartum, complete remission status, and age at diagnosis, 65Y vs greater than or equal to 65Y. Survival was greatest in patients with postpartum inhibitors, in those who achieved complete remission, and in those who were younger than 65 years. In some patients, such as those with postpartum or drug-induced inhibitors, the inhibitors may disappear spontaneously within a few months of after delivery or stopping the drug responsible. In contrast, patients with associated autoimmune disorders usually have high-titer inhibitors that seldom resolve spontaneously or with monotherapy with steroids. Patients with underlying malignancies may have a worse prognosis than patients without a malignancy. 50% to 70% of patients with underlying malignancies achieve complete eradication of the inhibitor. Nonetheless, the inhibitor may not always disappear despite successful treatment of the tumor. In addition, the reappearance of the inhibitor may not predict the recurrence of the malignancy. In the United Kingdom, approximately 20% of patients experienced a relapse after immunosuppressive therapy was discontinued. Relapse typically occurred between 1 week and 14 months after therapy was stopped. This finding reinforces the need for long-term follow-up of patients with acquired hemophilia. Most patients who relapse, 70%, achieve a second complete remission, although some may need long-term maintenance immunosuppression. Teed et al. Studied neutralizing autoantibodies against VIEN in acquired hemophilia and found that anti-VIEN IgA autoantibodies are predictors of poor outcome. Partial remission rates were similar in patients with and without anti-VIEN IgA autoantibodies, but IgA-positive patients had a higher risk of recurrence. Consequently, IgA-positive patients were less likely to achieve complete remission. Adjusted hazard ratio AHR 0.35, 95% confidence interval CI 0.18 to 0.68, P 0.01, and had a higher risk of death, AHR 2.62, 95% CI 1.11 to 6.22, P 0.05.